thanks to the organizing committee for this kind invitation. Today, I'm going to talk about an old technique that we use in orthodontic surgery every day, but applied to the treatment of the pathology of the mandible. As oral and maxillofacial surgeon, we receive a lot of third molar consultation every day. And to take it out, this is a procedure very simple. We perform at the office with under local anesthesia and in general without any problem. Sometimes the molars appears deeply inside of the mandible, and we have to take them out or split it in different parts, always in order to keep the most quantity of bone in that place. But we can do it without problems and with very good results related to the bone level in this site. But sometimes the molars or the cysts appears very deep in the mandible, like in this case, in which the roots are over the basal bone. So in those cases, you can have a lot of complications. The fracture of the mandible is one of them. So in the moment that you have to take it out, you have to prevent the occurrence of that kind of problem. And the injury or damage of the inferior alveolar nerve is another consequences of this deeper retention of the molars. Let me show you a small story about a young guy that appears in my office with his mother, who was a doctor and she knew me. He went to take out both teeth, second and third molar, and this cyst. And in the moment they started to work in that third molar, the mandible fractures. So they ran away from the dentist and came to my office. We perform under general anesthesia at the hospital, the treatment of that fracture. But this is the view of the fracture of the mandible in the moment that we open the flap. So imagine the problem for just a simple third molar. And we have to put rigid fixation, 2 plates, because the fracture was unstable. The result was good, no problems in the post-op and with mandible contour. But he needs a big operation. So when we have pathology inside, very deep inside of the mandible, it's a problem to make the choice of the approach of that kind of pathology. Why? Because if you want to do it by intraoral approach, you have lack of visibility. If you take out a lot of bone, you have problems with the residual bone, and you have the risk of pathology, fracture, or the injury of the nerve. The lack of visibility could be solved doing an external incision, but you add another possible complications, scar and facial nerve damage when the pathology is so deep. If you take out a lot of bone for taking out this molar that is retained, the problem is that you have a big cavity, we lost a lot of bone, and your mandible is weak. So in those cases, sometimes you have to put a rigid fixation just in order to prevent the fracture if the fracture is not produced during the procedure. And the injury of the inferior alveolar nerve is another possibility because it's very deep and you have not visibility when you are working at that level inside of the mandible. As we are oral and maxillofacial surgeons and usually perform a lot of orthodontic surgery, why not to use the sagittal split osteotomy as we usually do in orthodontic for taking out the third molar? Actually, several orthodontists forget the molars inside of the mandible during the pre-surgical orthodontics, and sometimes during our orthodontic procedure we have to take them out. So why not to use the technique for take them out in a very routinely approach in those cases. The technique was popularized by Hugo Ovegesser and was published first time by Trauner and Ovegesser in 1957 with two parallel cuts, the ramus of the mandible. But then along the years, several authors have made modifications according to the placement of the anterior cut or superior cut or the inferior border on the mandible. And lately, Villarnet, I'm a follower of Villarnet because I perform a lot of orthodontic surgery, talk about the short split of the mandible, and we use every day his technique. And this technique was applied to take out the pathology of the mandible, but a lot of authors, this is one of the first that have wrote about it. So let me show you how can do. We have the pathology here, so we place the osteotomy apart from the limits of the pathology. You can see here. Once we have marked with the piezo in the bone the osteotomies, we put the rigid fixation. Then we retire the rigid fixation and prepare and make the split of the of the mandible. And once we have the split did it, we take out the molar, the cyst, or whatever. Then we relocate the plates and the procedure is ready. Let me show you that was our first case. We nowadays have operated more than 15 cases with this technique. This is an old man that came to our office with a big cyst in the left mandible. We performed a biopsy with local anesthesia, and the result was odontogenic cyst. So, according that we have good limits of the pathology, we prepare to make that kind of osteotomy, sagittal split osteotomy, with the cuts very apart from the limits of the lesion. That was the occlusion preoperatively. You can see the flap, the anterior border of the mandible, and here you can see how we, with the piezo, we mark the osteotomy, anterior border, anterior osteotomy. Then we place both rigid fixation, all by intraoral approach. And then we made the split, and we have a good visibility to that area, and we didn't take out any kind of bone for doing that. We take out the teeth, we take out the cyst. You can see here the inferior alveolar nerve. We can take care of it because we can see it. Then we relocate the plates. We put in front all bone pieces, and we screw again the plates. This is 15 days after the surgery, and you can see the piece that we retired from that place. So we have published in 2015 a paper showing that when you maintain both cortical plates, you can avoid to put some filling material because you can obtain almost a complete regeneration of bone. And we, in that moment, we study about 18 patients, and you can see here how the percentage of the complete resolution related with the bone that was formed in those places. 100, 100, 100, a lot of them. So if you have a residual bone defect, but you have bone from both sides, buccal and lingual, you can not put nothing inside and you obtain a good result. This is the principle of using this technique for treating that kind of pathology. This is the 45 days after surgery control. So conclusions. This technique provides you a better access and good visualization. You can see all the place, you can see the nerve, you can see the limits of the lesion. How you see the nerve, you can dissect it and you can protect it. And how you maintain all the bone, the buccal cortical and the lingual cortical, you preserve it and you have bone contact and you don't need to fill it with any material. And as you work inside of the mouth, you avoid a potential facial nerve damage and the appearance of a bad scar in the neck. So we find indications, but as always, we have complications and limitations. It's a good technique for repair the inferior alveolar nerve if you have to do it by microsurgery, or to treat the deep pathology of the mandible. Several authors have published different kind of pathology treated by this technique. Which are the most common complications? A fracture can occur during the technique, so that in general have to be related with the thickness of the buccal plate. You need a complete buccal plate and you have to be trained in orthodontic surgery. So if you have a buccal plate complete, doesn't matter what happened with the lingual cortical. And you can use it placing the osteotomies apart from the limits of the lesion. We encourage to use that kind of technique, showing the literature. This article, they performed surgeries in 9 patients. 6 of them were made by extraoral approach and 3 of them by sagittal split osteotomy. You can see here the 3 of that were made by sagittal split osteotomy have no complications. So this is a very good technique. It's a safe technique in hands of a person who usually perform orthodontic surgery. So we encourage to all of you to use that technique for this kind of pathology. It's a very good technique and it has good results. Thank you for your kind invitation.